Hello, welcome to the second part of Chapter 28, the female reproductive system. Through this video, we will also go through all of the different disorders of the male and female reproductive system and different sexually transmitted diseases that are affecting both the male and the female reproductive systems. So our female reproductive system consists of the ovaries. The ovaries are also known as the gonads. The female gonads, ovaries, the male gonads were the testes. We have our uterine tube, oviducts, or ovarian ducts, fallopian tubes. Those are the uterine tubes as well, the uterus, the vagina, and then we have the external organs, the vulva, and the mammary glands. We're going to go through all of these different parts and what they do and how they work. So first are the ovaries. Females have 2 ovaries, just like males have 2 testes. The ovaries are going to produce gametes. For the females, they're going to be oocytes. We'll go through the different types, but eventually we come to these secondary oocytes that will become the ova or eggs once they've been fertilized. The ovaries are going to produce the different estrogens and progesterones for the body, inhibin and relaxin. Coming off of the ovaries, we have the uterine tubes that lead to the uterus. We have a bunch of ligaments that are going to help to hold both the uterus and the ovaries in place. The broad ligament of the uterus is actually part of that parietal peritoneum that we had mentioned in the digestive system. The mesovarium is what attaches the ovaries to that peritoneum. The ovarian ligament holds those ovaries to that uterus. We have a suspensory ligament. This is what's going to help to hold these ovaries to the pelvic wall. Just like the kidneys had a hilum, the ovaries also have a hilum because we need blood vessels, nerves to enter and exit these ovaries. So histologically, these ovaries contain this ovarian mesothelium. This is that surface. It's simple epithelium, and it's going to cover the entire surface of this ovary. We have the tunica albugina. It's a capsule. This one's connective tissue, and it lies underneath this mesothelium. The ovarian cortex is the next layer down because it is underneath that tunica albugina. This is where we have ovarian follicles, or we have collagen fibers and fibroblast cells that are known as the stromal cells. The ovarian medulla, this is the innermost portion. In this innermost portion, we have connective tissue, we have blood vessels, we have lymphatic vessels, we have nerves. There's a lot going on in all these different parts of the ovaries. The ovarian follicles, these are what will either they are or they will become these different oocytes. There's different stages that these cells will go through. An oocyte is an immature ova. If they have a cells, single layer of cells that surround them, they are follicular cells. They're going to form granulosa cells later in development. Once that single layer of cells becomes several layers of cells. Now we've come to that granulosa cells. These cells are providing nourishment. They're giving these oocytes all the different nutrients that they need to mature and develop. They start to secrete estrogens. This is what helps this ovarian follicle to grow larger. The tertiary ovarian follicle, this is a very large, it says fluid-filled ovarian follicle. This is one that we are ready to expel, get rid of during ovulation. The tertiary ovarian follicle is now at a stage where it is ready to be released out of that ovary. The corpus luteum, this is what is left after ovulation. After that secondary oocyte has been expelled out of the ovary, this is what is left. The corpus luteum is going to make progesterone. It makes estrogens, relaxin, and inhibin. And it'll either degenerate into scar tissue, which is known as that corpus albicans. It's going to continue to secrete out these different hormones until this degeneration happens. So here we can see parts of this female reproductive system. In white over here, we have this ovary. This was just what we were just talking about with all these different layers that contains all these different follicles that are in the different stages of development. This uterine tube, this is what is attached to this ovary. This uterus here is this broad, see lots of muscle through here. This is all we have talked about so far. Here is this picture in a cadaver. You can see this ovary. The uterine tube is what attaches to that ovary. Then we even have the uterus. This uterus stands more up than this picture below, but it sits just above that urinary bladder. So the female genital system, it's going to produce secondary oocytes, hormones, like that progesterone, estrogens, inhibin, and relaxin. Those uterine tubes, they're going to transport that secondary oocyte down to the uterus. The uterine tubes, new color, are where fertilization occurs. Fertilization of that oocyte actually happens in the uterine tubes. In this uterus, this is where implantation is going to happen. And this is where this fetus will develop during pregnancy. The vagina, this is what receives that penis during sexual intercourse. This is also considered a pathway for childbirth. Then those mammary glands, they are going to secrete, and eject milk. This milk is what nourishes the newborn and gives them the nutrients that they need, along with these different antibodies. Mom will share antibodies with the newborn through breast milk. So here we can see a slice again. Right through the middle, we see these ovaries in white. Here we can see that uterine tube that is connecting the ovaries down to that uterus. We can see this round ligament through here. We have this ovarian ligament through here that is helping to hold these ovaries to this uterus. You can see that mesovarium through this area between that uterine tube and those ovaries, we have that broad ligament. This is the area between the ovaries and the uterus. These are all helping to hold these different structures in place within the actual ovary. Now we've got a slice through the ovary. We have these ovarian follicles. They will differentiate into a primary ovarian follicle, which will become a secondary ovarian follicle, which will become a tertiary ovarian follicle, which will get expelled out. This is where this secondary oocyte here is being expelled out. And what is left is this corpus luteum. This is what is left. And this is what secretes out those estrogens, progesterones, relaxin, inhibin, all these different hormones after this secondary oocyte has been released. And then it slowly starts to degenerate till it becomes that corpus albicans. We have all these different layers. We have this ovarian mesothelium. Next, we can see this tunica albugina. We see the ovarian cortex, the ovarian medulla in the middle. We have this hilum over here that has the blood vessels, the nerves entering into that ovary. Here we can see a section of the ovary. You can see the different ovarian follicles kind of scattered throughout, and you can see they're different sizes because they're all in different stages. So oogenesis. Oogenesis is the formation of gametes in females. Like spermatogenesis was the formation of sperm in males. Now we're doing oogenesis, which makes those oocytes. In a female, this is going to start before they're born. Females are born with all of their oocytes in various stages already developed. So these cells are going to go through meiosis. And during meiosis, we're splitting off that DNA, those chromosomes. So each new cell will get one copy of the chromosomes. So during that fetal development, those primordial germ cells, they're going to start to migrate up to those ovaries specifically. These germ cells those primordial germ cells are going to differentiate into oogonia. These are diploid cells, so they have the full 46 chromosomes in them. These primordial germ cells that become oogonia are going to produce millions of germ cells. This is all happening during fetal development. Most of these cells degenerate. They degenerate down. That's atresia. We only maintain a small amount. Those are going to develop into those primary oocytes. The primary oocytes are the ones that enter meiosis 1. This is still going on during fetal development, but they do not technically complete meiosis 1 until after puberty has started. So now we have each of these primary oocytes. They're surrounded by these primordial ovarian follicles. They contain those stromal cells that have those collagen fibers and those fibroblast-like cells. So at birth, a female has between 200,000 and 2 million primary oocytes in each ovary. By puberty, because they start to degenerate, only about 40,000 of these are still present at puberty, and only about 400 will mature and ovulate during a woman's lifetime. The remainder of these degenerate down. So each month after puberty, when menstruation starts and the reproductive cycle takes place up until menopause, when there's no longer a menstrual cycle, this reproductive cycle is no longer happening at this point. So between that puberty and menopause, these different hormones, follicle stimulating hormone and luteinizing hormones, also known as gonadotropins, they get secreted. And they're going to stimulate the development of several of these ovarian follicles. But only one will reach maturity. Only one of them are actually able to get to the point where they can be released out. So every month, a few of these ovarian follicles will start to grow. They'll develop into those primary ovarian follicles. They're going to have those primary oocytes, and they're going to be surrounded by layers of other cells, those granulosa cells. This, as that follicle continues to grow, that primary ovarian follicle, it starts to get surrounded by this zona pellucida. And this is growing between the primary oocyte and those granulosa cells. These stromal cells that are those fibroblast-like cells, those stromal cells, they're at that basement membrane, so that very bottom of all of those cells, and they're starting to organize everything. They're the theca folliculi. So here we see this primary oocyte, that's this cell through here. We have those follicular cells. We have those stromal cells, even outside of that, with those collagen fibers kind of mixed between. And between those follicular cells and those stromal cells, we have that basement membrane. These cells are helping this primary oocyte start to mature. Here we can see on this slide, here's this primary oocyte through here. You see lots of those primordial follicles. You see a primary ovarian follicle, those granulosa cells, those theca folliculi, zona pellucida, all of this happening. This is around this secondary ovarian follicle. So as this primary oocyte continues to mature, we get those granulosa cells that surround this cell, that zona pellucida starts to become apparent here in purple. We also start to develop some of these theca cells. So we're developing all of these different cells are coming together to help this oocyte mature. So as maturation continues, this primary oocyte is eventually going to become a secondary follicle. This secondary ovarian follicle is going to have that theca interna. These are cuboidal cells, and they're going to secrete these different androgens. Androgens are those different sex hormones, so those estrogens, progesterones. The theca externa This is this outer layer of cells. This is where those stroma cells and those collagen fibers sit. Those granulosa cells, they secrete out that follicular fluid, which makes up the antrum. That antrum is found in the center of that secondary ovarian follicle. So this innermost layer of these cells become attached to that zona pellucida. But now they're called the corona radiata. So here's that antrum. That antrum, we get this whole space that starts to open up and it starts to fill up with fluid. We get that theca externa, that theca interna. Still see that zona pellucida, but now part of that's become that corona radiata. We still have that oocyte in the middle. This is known as a secondary ovarian follicle at this point. So here we can see it on a slide. You see this antrum. It's rather large, this antrum in here. There's a lot happening in this area. At this point, we have this secondary ovarian follicle with this oocyte in the middle, with all of these other cells helping this oocyte mature. So the secondary follicle just becomes larger and larger. It's going to turn into a tertiary ovarian follicle. This is right before ovulation happens. So we have a diploid primary oocyte. At this point, it's going to complete meiosis 1. We are going to split those 46 chromosomes from this haploid cell. So each new cell only has 23 chromosomes, one copy of each set of chromosomes. So we get a smaller cell and a larger cell out of this. The smaller cell becomes the first polar body. That gets discarded. We don't need that smaller cell. The larger cell becomes that secondary oocyte. This secondary oocyte begins meiosis 2, but it stops at that metaphase and it waits. We have this tertiary follicle. It's going to get released out. It's going to rupture the wall of that ovary where it is at, release that secondary oocyte outside of that ovary, which is known as ovulation. It technically gets, when it gets expelled out, it gets expelled into the pelvic cavity. It does get expelled out with that first polar body, just because of all of these cells that are around this. When this oocyte in the middle goes through that meiosis 1, there's still all this other stuff around it. It also expels out that corona radiata. The uterine tube has these little finger-like projections that come off of them that are known as fimbriae. They help to take this secondary oocyte and sweep it up into those uterine tubes. If fertilization does not occur, that secondary oocyte will degenerate. If fertilization happens, a sperm is able to penetrate into that secondary oocyte. That secondary oocyte is going to finish meiosis 2 after that sperm has already penetrated it. So before anything else can happen, that secondary oocyte will finish out meiosis 2. Again, they're going to split off into 2 different cells, that secondary oocyte. We will get a large cell that becomes the ovum or that mature egg, and then we get a smaller one that becomes that second polar body. When the sperm and the ovum come together, they form a diploid zygote, meaning they have 46 chromosomes now, 23 from the ovum, 23 from the sperm. They've come together, joined everything. Now we have a diploid zygote. So if this first polar body, if they go through meiosis again, another group of division, we end up with two polar bodies. The primary oocyte then will give rise to three haploid bodies. All are going to degenerate still, and we still have a single haploid ovum left. So here's this tertiary ovarian follicle just before it is ready to be expelled out. We even have a really cool electron micrograph showing this primary follicle or primary oocyte surrounded by all of these other cells making that secondary ovarian follicle. Here is the stage of meiosis. So we get this oogonium. This is a cell that has all 46 chromosomes. They will first go through mitosis. This is during fetal development. This is what gives us this primary oocyte. This primary oocyte, once it starts meiosis, will give us the secondary oocyte. The larger cell becomes the secondary, the smaller one becomes this polar body. A sperm comes along. A sperm penetrates the secondary oocyte. The secondary oocyte will finish meiosis too. That's what gives us the ovum with that sperm inside, and then our second polar body. With the sperm and that secondary or in that ovum, they come together to form that zygote. So this just kind of shows the different stages of where this follicle sits with all of these other cells around it, this oocyte, where these other cells are at, and what happens at ovulation. Ovarian cysts. Ovarian cysts are little fluid-filled sacs that can be found in or on an ovary. They're pretty common. They're usually non-cancerous, and they tend to disappear on their own. In women over 40 is when we start to see more cancerous cysts develop. It can cause pain, pressure, ache. It can cause more of a fullness in the abdomen. They can also feel pain during sexual intercourse. Delayed, painful, or irregular menstrual periods because of these ovarian cysts. If one of these ovarian cysts erupts, breaks, it can cause a lot of different problems, but that's pretty rare. Most cysts, since they tend to go away on their own, they don't really require much treatment, but if they become too large, they start to disrupt other functions. They cause a lot of pain, irregular bleeding, vaginal bleeding. They can be surgically removed. These uterine tubes. So we have two of these uterine tubes, or as I mentioned at the beginning, they also known as fallopian tubes or ovarian ducts. They extend off of the uterus, and they come out by the ovaries. They are found within that broad ligament of that uterus. And it's both a route for the sperm to reach that ovum and to transport that secondary oocyte and fertilized ovum or ova from the ovaries to the uterus. At the top, there's this funnel shape that's known as the infundibulum. This funnel shape, it's close to the ovary. It's not completely over top of it, but that's to help act like a funnel to catch that secondary oocyte. those finger-like projections that I mentioned before, those fimbriae, those are at the top right next to the ovaries. So from that infundibulum, this uterine tube is going to extend down, kind of travels in the ovary, it kind of goes down and around into that uterus. We have the ampulla. This is the widest portion. And then we have the isthmus. This is a more narrow portion. And this is where it joins the uterus. So histologically, we have that mucosa, we have a muscular layer, and we have a serosa. So this mucosa, this is that inside layer, and it's going to be ciliated simple columnar epithelial cells. The cilia beat to help move that ovum down that uterine tube. We also have PEG cells, which are non-ciliated, but instead they have microvilli. They provide a fluid that's going to help get this ovum these different nutrients that it's going to need to survive, to go through its final stages of meiosis too. That muscular layer, we have smooth muscle. They are helping with peristaltic types of contractions to help push along this ovum once it has been fertilized, or this oocyte. And then on the outside, we have the serous membrane, and that is just attaching this uterine tube to that visceral peritoneum. So after ovulation has occurred, those fimbriae provide this movement that helps to draw this oocyte into those uterine tubes. They're trying to keep that oocyte kind of dropping down specifically into that tube. Sperm tend to encounter and fertilize that secondary oocyte at the ampulla. So towards the top of that uterine tube. Fertilization can occur up to 24 hours after ovulation. Hours after fertilization, that nuclear material, that DNA, of the ovum and the sperm are going to unite. They come together to form that zygote. This is when cell division, rapid cell division, starts to occur. These cells are going through this constant rapid division as that ovum or zygote is traveling towards the uterus. It takes almost a week for that zygote to make it to that uterus. If that secondary oocyte does not get fertilized, it just disintegrates. It's done. So here we can see, here's this ovary here with this uterine tube. You can see these kind of finger-like projections. If I kind of zoom in a little bit here, these little fingers, those fimbriae, this is what helps to draw that oocyte that was released inside. Then once we get inside, we get this ciliated simple columnar epithelium. And then we have those PEG cells that have that microvilli on it. These are helping to sweeping motion to move that oocyte down that uterine tube, along with the peristaltic contractions from the smooth muscle that is in that uterine tube to help this oocyte, ovum, zygote, whatever stage it may be in, to get down to that uterus. So once we get down to the uterus has few functions here. It's a pathway for sperm to help get to those uterine tubes. It's the site of implantation of this fertilized ovum. It's where that fetus is going to develop during pregnancy. Labor occurs at the uterus. If implantation occurs, pregnancy happens. If implantation does not happen, that uterus is the source of that menstrual flow. So within the uterus, it sits above the bladder. It's kind of an inverted pear, so it's kind of an upside down pear shape. In a female who has never been pregnant, their uterus is about 3 inches long and about 2 inches wide. The uterus is larger in a female who has been pregnant. It deteriorates down smaller after menopause. So the top part, the dome at the top, that's where this fundus is found. The body, kind of that middle portion, that body of the uterus. It's all through here. The cervix. The cervix is the opening to that uterus. The isthmus is kind of this area between the body and the cervix. We have the cervical canal. That is this inner side portion here. We have the internal os and the external os. The internal os is found up through here. Well, that external os is going to be this bottom portion. So these are all the different parts of the uterus. The uterine cavity is just the interior, the whole inside of this uterus. The uterus normally sits in what is known as an anteflexion position. So it kind of sits anteriorly and superiorly over that urinary bladder. The cervix is going to kind of go inferior and posterior. Then we have all those different ligaments we mentioned, that broad ligament. We have uterosacral ligaments. Connects the uterus to the sacrum. The cardinal ligaments. They go from that pelvic wall to the cervix and the vagina. The round ligaments. This is in part of that broad ligament. If the uterus is sitting in a posterior tilting, it is known as retroflexion. There is no harm in the uterus sitting in this retroflexion position. It's just something that happens with some people. So a uterine prolapse. This is where this uterus kind of falls down or goes backwards, because these supporting ligaments that are supposed to help hold it in place may get weak. The muscles in that pelvis start to atrophy. If you have a very traumatic vaginal delivery, it can cause a uterine prolapse. Coughing, straining, difficult bowel movements, pelvic tumors, We have a first degree, which is pretty mild because that cervix remains in that vagina still. The second degree, that cervix starts to protrude through the vagina. While the third degree, the entire uterus is outside of the vagina. So we come back up to this picture here. The vagina is this tube that kind of sits underneath the uterus. So the uterus is going to have different layers to it, just like everything else does. Metrium means the uterus. So perimetrium, that's part of that visceral peritoneum. It has, part of it becomes that broad ligament. We get this vesicoderine pouch. This is between the uterus and part of that urinary bladder. It has a little pouch between it. We have the rectouterine pouch, or pouch of Douglas. That's the name I learned it as. That's between the back of the uterus and that rectum. Myo, muscle. So the myometrium is the muscular layer, that layer of smooth muscle fibers. They're thickest at the top and thinnest at the bottom. There's a circular layer, longitudinal and oblique layer. So oxytocin is the hormone that triggers contractions of the uterus during labor and childbirth. So that myometrium will respond to this oxytocin that comes from that pituitary, which causes that myometrium to actually fully contract, which helps to push that fetus out of the uterus. Now, the endometrium, that's the innermost layer. It's very highly vascularized, and we have many layers to it. We have a compact layer, again, superficial cells. These are ciliated columnar epithelium and non-ciliated secretory columnar epithelium. We have endometrial stroma within this compact layer of connective tissue. We have these little tubes, tubular uterine glands that start to develop. This is the layer that is sloughed off during menstruation. It's this endometrium, this compact layer. The functional layer. These are endometrial stroma cells. Again, we've got that areolar connective tissue. This is also sloughed off during menstruation. And then that bottom layer, the basal layer. We have more of those endometrial stroma cells. It's highly cellular. There's lots of cells going on in there. But this is a permanent layer because it's the basal layer contains stem cells. So this is the layer, these are the layer of cells that are going to regenerate both that functional and that compact layer at the top. So here we can see, here's that myometrium, that muscle. Here we can see that basal layer. So all of these cells through here are going to always remain. The rest, this functional layer, and most of that's a functional layer, this compact layer at the top, this is what gets shut off during menstruation. Here we can see an endometrial gland that has developed. This kind of invagination of this tissue that comes down, and then we have those endometrial gland cells that are secreting out different substances. So the arteries that go to the uterus are known as the uterine arteries, and they come from that internal iliac artery. eventually we're going to get these arcuate arteries that'll branch into radial arteries. And before they enter that endometrium, we get straight arterioles and spiral arterioles. The straight arterioles are going to go to that basal layer. The spiral arterioles go to that functional layer. So we can see some of these different arteries. You see these spiral arteries through here. You see these straight arteries, straight arterioles that are feeding these different layers. Here's this arcuate artery before it goes in and starts to feed into that wall specifically. So cervical mucus. Cervical mucus comes from secretory cells. It's going to be water, glycoproteins, lipids, enzymes, and different salts. This cervical mucus is produced during these reproductive years. Females are going to secrete out 20 to 60 milliliters of this cervical mucus per day. What this cervical mucus does is it makes that vagina, that uterus, more hospitable. Because the sperm need to be able to come in and make their way through. It's less viscous right around the time of ovulation. It's more alkaline, so it's not as acidic as other times. So at other times, it's going to form this cervical plug. Means it's plugging up that cervix. So it prevents sperm from even penetrating into that uterus. The cervical mucus, it gives energy because it has lipids, glycoproteins. It's helping that sperm to move. It also plays a role in capacitation of sperm. So in the female genital tract, this capacitation helps them to fertilize that secondary oocyte. It causes the tail of the sperm to move faster, allows that sperm to keep the swim on. A hysterectomy. Not performed as much as it used to be back in the day, but it's where they actually remove the uterus for different reasons. Technically, it is the most common gynecological operation, still done, not as often, but it can be done because of fibroids. Fibroids tend to be non-cancerous tumors that grow within the uterus. Someone who has endometriosis, this is where that endometrium grows other places in the pelvic cavity outside of the uterus. Pelvic inflammatory disease, ovarian cysts, excessive uterine bleeding, cancer of the cervix, uterus, ovaries. You can do a partial hysterectomy where they get rid of that uterus. That cervix is left. A complete hysterectomy, the uterus and the cervix is removed. A radical hysterectomy, this is probably the one that's due the least often. It just depends, could be because of cancer, but they're going to take out the uterus, the cervix, the uterine tubes, and maybe even the ovaries. They can remove part of that vagina as well. Depending on what it is, they could remove lymph nodes. So they can do an incision, or they can technically take it, do a hysterectomy through the vagina even. So that vagina, that is this 4-inch tube that connects the uterus to the exterior of the body. So it's that receptor for the penis during sexual intercourse, and it's that outlet for that menstrual flow, as well as passageway for childbirth. It is between the urinary bladder and the rectum. The fornix of the vagina, this is kind of what surrounds that vagina that attaches to the cervix. People who use a contraceptive diaphragm, it actually rests in that fornix. A diaphragm is kind of like a plug that doesn't allow sperm to the cervix at all. The mucosa. This is continuous with that uterus. It's non-keratinized stratified squamous epithelium with alveolar connective tissue. And it has all these different transverse folds throughout that are known as the vaginal rugae. We have dendritic cells that are going to be found in that vagina. We have those antigen presenting cells. These are the cells that participate in the spread of HIV. There's a lot of glycogen stores in the vagina. It tends to be a pretty acidic environment because we're trying to prevent microbial growth. We're also trying, it's harmful to sperm. So this is why when we talked about in the male reproductive system, the different secretions out of the male reproductive system to try to neutralize the acidic environment of the female genital tract. So here we can see the non-keratinized stratified squamous epithelium that is lining most of the vagina. So during childbirth, the episiotomy, this is the emerging of that fetus. It starts to stretch that perineal region, which is the floor of that pelvic cavity. That stretching could be excessive, and that's where a physician may actually cut between the vagina and the anus to help widen that birth canal. Depends on how large the head is and how much extra stretching. Very large fetus, breech, that's where the butt's coming out first. If that fetus is in distress, their heart rate is too high. Sometimes they have to use a forceps, kind of grab a hold of that head and pull. Or if their perineum is very short, that incision will get stitched back up after delivery. So this vagina also has muscular layers to it. It has an inner layer, circular, outer longitudinal, smooth muscle, stuff we don't control. The adventitia is that superficial layer. It's areolar connective tissue. The hymen. The hymen is a mucous membrane that kind of forms around this inferior end of that vaginal opening, that vaginal orifice. It could be different sizes. Sometimes it's not even present. Sometimes it can completely cover that vaginal opening. Other times we have an imperforate hymen. That's where it's completely covers and they need to surgically cut it open to allow menstrual flow to actually occur. The vulva. Now we're getting into the external genitals in a female. So the vulva is the name for many different components. We have the mons pubis. This is in the front. It's a lot of adipose tissue, and it's kind of covering that pubic symphysis. The next part down, we have these two longitudinal folds of skin that are known as the labia majora. These are covered with pubic hair, just like that mons pubis is. The inside of the labia majora, we have two smaller folds. Those are known as the labia minora. This does not have pubic hair, and we have different sudoriferous glands. They're going to produce some sort of antimicrobial substance, and they help to produce lubrication during sexual intercourse. The clitoris. The clitoris is made up of two small erectile bodies. They're the corpora cavernosa, and then there's millions of nerves and blood vessels that go to this clitoris. Maybe not millions, but hundreds of thousands. In the clitoris, it sits just in front of that labia minora. There's a prepuce that is going to cover that clitoris up. The part that we can see is known as the glans clitoris. The clitoris is capable of enlarging and becoming erect. It has that erectile tissue. So during sexual excitement in a female, that clitoris is can become erect itself. The vestibule. That is what is found between those labia minora. So that's where that hymen will be found. We have the vaginal orifice, the external urethral orifice, and then we have different glands. We have the vaginal orifice, which is the opening to that vagina, the external urethral orifice, which is going to be that opening to the vagina, or to that urethra. Where we're going to find that clitoris within there. We have the paraurethral glands, and they're going to help secrete mucus in that urethra. We have the greater vestibular glands. They're on that vaginal orifice. And then we have the lesser vestibular glands, and they also secrete out mucus. We have the bulb of the vestibule. Again, more erectile tissue that's in that labia. And this is going to become engorged with blood during sexual arousal. So if we see, look, that mons pubis is in the front. It's a lot of fat that's going to protect that pubic symphysis. We have the prepuce of the clitoris. So underneath it, we have the clitoris. We can see the labia majora, which are the two larger folds in that skin. The labia minora is smaller folds in that skin. The hymen is the skin that is partially covering that vaginal orifice. Here you can see that external urethral orifice in front of that vaginal orifice and that anus behind. So here's the comparison of the male to the female. What parts actually transfer between sexes here? The perineum. The perineum is this diamond-shaped area that goes from the medial thighs and the buttocks of males and females. So the external genitals and the anus are going to sit in this diamond. The pubic symphysis is found in the front, the ischial tuberosity is at the side, and that coccyx in the back to kind of give you that visual picture. So you can draw transverse lines from the tuberosities, And that will give us an anterior urogenital triangle and a posterior anal triangle. So here we can see the black line shows that whole triangle. Divided, get a line, draw a line that gives us that urogenital triangle in the front, this whole area, and the anal triangle in the back. This is the whole area that makes up that perineum specifically. Mammary glands. So mammary glands are found in front of that pectoralis major and muscle and serratus anterior. And these mammary glands are attached by fascia. Part of these mammary glands, we have that nipple. That nipple is the pigmented portion. Has the openings to the lactiferous ducts, and this is where milk comes out. The areola is still that pigmented area that's around the nipple. This is mostly sebaceous glands through here. We have suspensory ligaments. This is connective tissue between the skin and fascia, and it helps to support the breasts. With age, they become looser. With excessive strain, they become looser. High impact exercises without support. This is where supportive bras can help with maintaining the tautness of these suspensory ligaments longer. So these mammary glands are considered modified sudoriferous glands that are going to produce milk specifically. So each mammary gland has 15 to 20 lobules or compartments. There's adipose tissue that is found between them. So each lobe is broken down into, this is 15 to 20 lobes, and each of these lobes are broken down into lobules. Lobules are these clusters of these glands, glandular alveoli. So contraction of the myoepithelial cells will help take milk and project it towards that nipple. So when this milk is being produced, it's going to pass from that alveoli into these tubules, secondary tubules, that'll lead into the mammary ducts. These mammary ducts are going to form sinuses that are known as lactiferous sinuses. Milk can be stored in these sinuses until they are drained out of those lactiferous ducts. So the function of the mammary glands is to make, secrete, and eject milk, known as lactation. This milk production comes from progesterones and estrogens, but mostly from that prolactin. Oxytocin causes the ejection of milk, and it's usually in response to suckling. So we can see the nipple with the areola, which is that whole pigmented portion. You can see all of these different lobules. They lead to these tubules that are going to lead. We have these mammary ducts that are finally going to lead to that nipple that allows milk to be ejected out. Breast augmentation. This is where breast size can be increased. Augmentation is an increase. It can be done for females who are not happy with their breast size. It can help to restore volume during weight loss, following a pregnancy, try to lift. After removal of the breast for breast cancer, breast augmentation surgery, this is where after breast cancer where the whole breast needed to be removed. Sometimes people will do breast augmentation to restore even having a breast. They can be made of saline solution or a silicone gel. A breast reduction. This is where the breast size gets reduced. They will remove fat, skin, and some of that glandular tissue if needed. People have chronic back pain because of larger breasts, neck pain, shoulder pain. It can cause poor posture, cause breathing problems. If you get really deep grooves in your shoulders from bras and clothing, it could be a sign that you could be a candidate for breast reduction. Fibrocystic disease. This is the most common cause for a lump to be found in a female breast. It's finding cysts. It occurs mainly in women between 30 and 50, and it could be because of too much estrogen or a deficiency of progesterone in this post-ovulatory luteal phase. So one or both breasts may become lumpy, swollen, or tender before menstruation happens. So let's look at this female reproductive cycle. We've been through all the parts of the female reproductive system. Now we'll go through this whole reproductive cycle here. So this is during reproductive years in a non-pregnant female. They have pretty normal cyclical changes. So happens cycle after cycle. During the ovarian cycle, these ovaries are going to mature an oocyte during this ovarian cycle. The uterine cycle is happening at the same time. So there's changes in that endometrium to prepare for that fertilized ovum to implant. If fertilization of an ovum does not happen, those hormones coming from that ovary, that corpus luteum, is going to die off. And that is when that endometrium starts to slough off. So this whole cycle is made up of ovarian and uterine cycles taking place. There's hormonal changes that regulate them. So start with the hormones. Gonadotropin releasing hormone. This comes from that hypothalamus, and it's going to help to control these different uterine and ovarian cycles. Gonadotropin releasing hormone is going to cause follicle stimulating hormone and luteinizing hormone to be released. Follicle stimulating hormone is going to cause that follicle to start growing. Luteinizing hormone is going to continue that follicular development. They're going to both cause estrogens to get secreted by that ovary. Luteinizing hormone is going to help with producing those androgens. Follicle stimulating hormone and those different androgens will get converted to estrogens. Luteinizing hormone is going to trigger ovulation and cause that formation of that corpus luteum. When that corpus luteum gets created, it's going to produce estrogens, progesterone, relaxin, and inhibin. There's at least 6 different types of estrogens that females secrete, but we only can monitor 3 of those. So that gonadotropin releasing hormone causes follicle stimulating hormone and luteinizing hormone to be released out. They travel through the bloodstream to get to the ovaries to cause that oocyte to mature, cause that oocyte to get released out, cause that corpus luteum to be developed and secrete out estrogens and progesterones. So these different estrogens. Estrogen is going to promote the development and maintenance of the female reproductive system structures. It increases protein anabolism. Estrogen is what helps to keep bones strong and help to work with growth hormone. Estrogens will lower your blood cholesterol level, which is why women under 50 have a lot lower risk of coronary artery disease than men. Each month when menstruation occurs, estrogens will cause that proliferation to form a new layer of that uterus. And then levels in the blood will inhibit the release of gonadotropin releasing hormone and the secretion of luteinizing hormone and follicle stimulating hormone. So moderate levels of those different estrogens. Progesterone. This comes from that corpus luteum. And it works with estrogens to get that endometrium ready for implantation. It prepares those mammary glands for milk secretion. Relaxin. Relaxin is an awesome hormone. It comes at first from that corpus luteum. It relaxes the uterus. It prevents contractions of that myometrium. So it allows that ovum to implant into that uterus. Relaxin being produced by that corpus luteum will eventually get that placenta to start releasing more relaxin. And it'll continue to relax that uterine smooth muscle so that it can continue to expand as that fetus develops. At the end of pregnancy, relaxin is going to increase the pubic symphysis flexibility so that fetus can fit through that the uterus out and through that vagina, through that delivery canal. Since relaxin is technically secreted into the bloodstream, it works to kind of relax the entire body as well. Inhibin. This comes from those granulosa cells that are making follicles and the corpus luteum. It helps to inhibit, it's inhibiting something, follicle stimulating hormone and somewhat luteinizing hormone. So during this reproductive cycle, it can range from 24 to 36 days. Every female is different. Every female, a lot of females, their cycle is going to be different every month even. So there's technically 4 phases to it. We're going to look at it in a 28-day cycle because that tends to be the average is 28. So we're going to look at the menstrual phase, the pre-ovulatory phase, ovulation, and post-ovulatory phase. This is what's happening in each of these phases here. So during that menstrual phase, we're shutting off that endometrium. Pre-ovulatory phase, that endometrium is regrowing. Then ovulation, now we have this secondary oocyte that's been released. This corpus luteum is starting to send progesterone and estrogens to that uterus to help grow up that endometrium even faster. So if this ovum gets fertilized, it has a place to implant in. So we can see all these different hormone levels. They're pretty low during those menstrual days. Estrogens start to peak. Luteinizing hormones start to peak right about ovulation. Then progesterone and estrogen goes back up during this post-ovulatory phase. So let's go through each of these. Menstrual phase, also known as menstruation or menses. It's about 5 days of this cycle on a 28-day cycle. So with the ovaries, this follicle stimulating hormone from the pituitary is going to cause these primordial ovarian follicles to develop into primary ovarian follicles and then to secondary ovarian follicles. It's going to take months for these to fully develop. These ovarian follicles that are developing, it starts to develop at the beginning of the menstrual cycle. They may not reach maturity and ovulate for several menstrual cycles later. So at the uterus, this is where this menstrual flow is happening. It can cause the loss of 50 to 150 milliliters of blood, tissue, mucus, and epithelial cells. This is when the estrogen and progesterone levels have declined down. That causes prostaglandins in those uterine spiral arteries to constrict off, cut off that blood supply. They become oxygen deprived and start to die. That entire functional and compact layer eventually gets sloughed off. Pre-ovulatory phase. So this is at the end of menstruation to the beginning of when ovulation occurs. It can last from 6 to 13 days in a 28-day cycle. It's pretty variable in length, honestly. So at the ovaries, this secondary ovarian follicle will start to secrete estrogens and inhibin. Around day 6, this secondary ovarian follicle with one or two ovaries, in one of the two ovaries, has outgrown every other one. It'll become that dominant ovarian follicle. Estrogens and inhibin get secreted out by this dominant ovarian follicle that will cause a decrease in that follicle stimulating hormone so that these other follicles start to degenerate, the ones that did not grow enough. Fraternal twins, so non-identical twins or triplets, this is when 2 or 3 of those secondary ovarian follicles actually become codominant. So 2 or 3 get ovulated and fertilized. So 2 or 3 of these oocytes get released out and they become fertilized at the same time. So with just one, this one dominant secondary ovarian follicle will become a tertiary ovarian follicle. It continues to enlarge and enlarge till it's ready for ovulation. It's going to cause a swelling at the antrum of the ovary. This tertiary ovarian follicle is increasing the amount of estrogens that it's going to produce. Then we come to this follicular phase, which is the menstrual and pre-ovulatory phases together. That's what makes up this pre-ovulatory, everything that's happened so far. At the uterus, estrogens are being released into the blood flow from these ovarian follicles. It's causing the repair of the endometrium that was just shedded off. That basal layer goes through mitosis, and these cells are going to continue to grow and grow as this endometrium continues to thicken. The arterioles are going to coil and lengthen into this functional layer again. This endometrium by ovulation will about double in size. This is also known as the proliferation phase because that endometrium is proliferating. It is dividing and dividing and dividing. Next, we come to ovulation. This is where that tertiary follicle is going to rupture out of that ovary and we release that secondary oocyte. This is usually around day 14 of a 28-day cycle. So that secondary oocyte is going to kind of remain surrounded by the zona pellucida and cona radiata. These estrogen levels that are very high give a positive feedback that causes luteinizing hormone and gonadotropin releasing hormone. This is what causes ovulation. So these higher concentrations of estrogen stimulate more gonadotropin releasing hormone from that hypothalamus, which stimulates gonadotrophs from the anterior pituitary to secrete that luteinizing hormone. Gonadotropin releasing hormone promotes the release of that follicle stimulating hormone. Luteinizing hormone causes that rupture of that tertiary follicle, that secondary oocyte. It's expelled out of that ovary about 9 hours after we see a peak surge in that luteinizing hormone. That ovulated secondary oocyte and its cona radiata gets swept up into that uterine tube at this point. So during this ovulation, once in a while, this oocyte will get lost into that pelvic cavity. It didn't get swept up into that uterine tube. It will disintegrate. Blood may leak into the pelvic cavity because of this follicle, and it can sometimes cause pain. Mittelschmerz. That's what this is known as. There's different home tests that can actually detect that rising level of luteinizing hormone that can actually help to predict ovulation a day in advance. So all of these different hormones are causing more hormones to be released that are helping to mature and get this oocyte ready to be released out. This post-ovulatory phase. So this is between ovulation and the onset of the next menses. So it's from about day 15 to 28. So at the ovary, after that ovulation, what is left is that corpus luteum. So after that follicle has been released, some of these cells start to break down. We form a blood clot from that rupture of that follicle, the corpus hemorrhagicum. That corpus luteum is going to secrete out that progesterone, estrogens, relaxin, and inhibin. And then we have our luteal cells that are going to actually come in and absorb that blood clot during the luteal phase. During this post-ovulatory phase, the next events are going to depend on if the follicle is fertilized or not. So if there's no fertilization, that corpus luteum only has a lifespan of 2 weeks. After those 2 weeks, it's going to degenerate into that corpus albicans. So progesterone, estrogens, and inhibin start to decrease. Gonadotropin releasing hormone, follicle stimulating hormone, and luteinizing hormone are going to start to rise because of negative feedback suppression. Those progesterone, estrogens, and inhibin are preventing those gonadotropin, follicle stimulating hormone, and luteinizing hormone from being released. Once that stops, these hormones start coming back up again. Follicular growth is going to start to resume again, and new ovarian cycle is going to begin. If that secondary follicle is fertilized, it's going to begin to divide. That corpus luteum is going to persist. It's going to stay longer than those 2 weeks. That's where human chorionic gonadotroph HCG starts to get produced by that embryo 8 days after fertilization. This is what causes that corpus luteum to remain, to continue to secrete out those hormones. We can start to detect this HCG in the maternal blood or urine as an indicator of pregnancy. So this is what home pregnancy tests are detecting, this HCG that can be found in the urine. So what's happening at the uterus during this post-ovulatory phase? So progesterone and estrogens that are coming from this corpus luteum are causing this endometrium to continue to grow thicker. The coiling of endometrial glands are being formed. And then the secretory activity in these endometrial glands, they start to secrete glycogen during this secretory phase of the uterine cycle. So these changes kind of peak 1 week after ovulation because that is when this ovum, if it was fertilized, would arrive at the uterus. If that fertilization does not occur, progesterone and estrogen start to decline because that corpus luteum is going to degenerate. As this progesterone and estrogen levels go down, that is what starts menstruation. The female triad: disordered eating, amenorrhea, and premature osteoporosis. So females in their reproductive cycle can actually disrupt this whole entire cycle for many different things. Losing a lot of weight, low body weight to begin with, disordered eating, or vigorous physical activity. There's a lot of athletes that actually experience this. They want to lose weight to improve performance. This can cause eating disorders. Amenorrhea is the absence of menstruation. Outside of this female athlete triad, amenorrhea, most common causes are pregnancy and menopause. But in female athletes, it's because of this gonadotropin releasing hormone that gets like a reduced secretion of it. It's not secreted as much. We also get decreases in the release of luteinizing hormone and follicle stimulating hormone. So these follicles are not developing. So ovulation does not occur. So estrogens and progesterones that usually decline after ovulation start that monthly bleeding. But in these female athletes, none of this process is happening. It's more common in young women, teens, with very low amounts of body fat. They usually have low levels of leptin from those adipose cells because they don't have a lot of body fat to begin with. Estrogen is what helps to maintain your bone calcium levels. If you're not secreting out enough estrogens, this is what causes osteoporosis to develop at a very young age. Short periods of amenorrhea are usually not harmful, but if it lasts for very long periods of time, it can cause a very low bone mass. So this chart here shows the negative and the positive feedbacks of how these different hormones, these different cycles, everything that is happening within the uterus and the ovaries are causing all of these different stages to occur. Birth control methods or contraception. This is known as the restricting of the number of children by controlling the fertility. There is no ideal method of birth control besides complete abstinence. Complete abstinence is the only 100% effective way to prevent pregnancy. There's a lot of different methods available. surgical sterilization, hormonal methods, intrauterine devices, spermicides, barrier methods, or periodic abstinence. So this chart goes through the failure rates, if it's used perfectly and how it's normally used. A vasectomy. This is done in men. There is still a chance, and I know several people where the male has had a vasectomy and was still able to impregnate their wife. I know I've seen it happen on many occasions. Tubal ligation, that's more done in females. Sterilization still has a very low rate. Oral contraceptives. Oral contraceptives, they advertise they're about 99% effective. There's still that 1% chance that they're not going to work right. There's lots of different kinds. There's skin patches, there's vaginal rings. Using that emergency contraception, there's still a 25% chance that that's not going to work. There's different hormonal injections, there's intrauterine devices, spermicides. Just a spermicide alone is still a pretty high chance. Condoms, vaginal pouch, diaphragm with spermicide. Spermicide is supposed to help kill sperm. Cervical cap with spermicide. The rhythmic method, the symptothermal method, no method at all. So we'll go through some of these. Vasectomy. Vasectomy is where the vas deferens is cut, is removed. So the sperm that are being produced in the testes have no way to get to that urethra to finally be expelled out. The problem is sometimes they still seem to find a way. The nice thing with a vasectomy is it can be reversed. Tubal ligation. This is sterilization in females. So those uterine tubes are tied closed and cut. That secondary oocyte can't get into that uterine tube and sperm cannot reach that oocyte. So they cut off and tie that ductus deferens versus that uterine tube. Males, it's reversible. Females, it's not. So that is sure, which is another, it's a non-incisional sterilization. So they use a catheter, they insert a catheter into that vagina through the uterus, into that uterine tube. So they're trying to promote the growth of scar tissue. So it kind of blocks that uterine tube. And those hormonal methods, pills, extended birth control cycles. The combined pill is progestin, and estrogens, and they tend to be taken on a 3-month cycle. So you only see that menstrual cycle once every 3 months. The extended cycle birth control, again, is progestin and estrogen. It's once a day for 3 months, so that's another 3-month cycle. The mini pill is progesterone only, and it's taken every month, and you don't see that menstrual cycle at all. There's skin patches, progestin and estrogen. This is put on for about 3 weeks at a time and then removed for a week. That vaginal contraceptive ring, it has estrogens and progesterone in it, and it is inserted up into that vagina. It's left in for 3 weeks and then it's removed. That emergency contraception or that morning after pill, it has that progestin and estrogens or progesterone. This is Morning after pill, it is following unprotected sexual intercourse. Next day. It prevents that follicle stimulating hormone and that luteinizing hormone from being secreted out. It causes those ovaries to stop secreting their own estrogens and progesterone. So it starts to decline off, which is trying to cause this shedding of this uterine lining. When that uterine lining sheds off, that oocyte or that ovum can no longer implant, or that zygote at this point even. So you're taking one pill within 78 hours of coitus, sexual intercourse, and then a second pill 12 hours later. Now there's hormone injections where they're giving progestins, which is a form of progesterone, every 3 months. Intrauterine devices. This is something that is stuck up into the uterus to prevent fertilization, blocking sperm from getting into those uterine tubes, and they can be used for up to 10 years. Spermicides, there's a lot of different kinds, but their main purpose is they contain sperm killing agents. So those sperm get killed upon ejaculation. The male condom, a latex covering that prevents sperm from entering that female reproductive tract. We have that vaginal pouch of the female condom, which also prevents sperm from entering the uterus. The diaphragm, like this rubbery dome type of thing that can be inserted up to 6 hours before, but it does not protect against STDs, and that vagina is still technically exposed. The cervical cap, it's like the diaphragm, but smaller, but it fits over that cervix. Abstinence, or periodic abstinence. So monitoring a female reproductive cycle and seeing all these different physiological changes that occur, and then abstaining from intercourse on the days when ovulation, when pregnancy is most likely to occur. The rhythm method, this is a method that was developed in the 1930s, and it's abstaining from this sexual intercourse on days specifically when ovulation is likely to happen. So 3 days before ovulation and 3 days after. It's a very poor effectiveness because female reproductive cycles are so irregular. It's very rare to find a female's reproductive cycle that is spot on the same every single month. Symptothermal method. This uses different physiological markers, like during ovulation, our basal body temperature goes up. There's clear, stretchy cervical mucus that gets expelled that looks more like uncooked egg whites. Let's ruin some foods. Looking at those different hormonal changes. You're using charts to help analyze all of this. Abortion. An abortion is a premature expulsion of the products of contraception from the uterus. It is a medical procedure, so that is how we're talking about it here. We're not going into politics or anything. It is just a medical procedure. And it usually is done before the 20th week of pregnancy. Sometimes an abortion is natural, which is known as a spontaneous miscarriage. It can be intentionally performed. It can be induced. So there's different ways to induce an abortion. Mifepristone or RU46, it's this hormone. So if somebody's been pregnant for 9 weeks or less, they're given this medication. It's an anti-progestin, so it's going to block progesterone from binding to these progesterone receptors. So if these levels of progesterone fall during pregnancy, or if it's blocked completely, this is what's causing menstruation to occur. So that embryo is going to get sloughed off with that uterine lining. This endometrium will start to degenerate within 12 hours of this medication. And with 72 hours is when menstruation usually starts. It actually starts to stimulate uterine contractions to expulse, to get rid of that endometrium. It can be pretty painful from what I've heard from some friends that have had some spontaneous abortions or a miscarriage. When these uterine contractions randomly start, it gets very painful. There's a vacuum aspiration or a suction. This can be done up to the 16th week. So they stick a tube up into the uterus with a vacuum attached to it. The embryo or fetus, the placenta, and the lining of that uterus is all suctioned off. There's dilation and evacuation. This is for between 13 to 16 weeks. So once that cervix becomes after it becomes dilated, they'll use suction and forceps to remove the fetus, the placenta, and that uterine lining. A late stage abortion is anything from 16 weeks to 24 weeks. This is where they have to use different surgical methods. They also have different non-surgical methods. There they use a saline. There's medications to induce abortions. Labor may also be induced using suppositories or injections into the amniotic fluid through the uterus. So the development of of our genital system. So each of these, that secondary oocyte and that sperm, contain 23 chromosomes that come together to make 46 chromosomes. There's 22 pairs of autosomes and 1 pair of sex chromosomes. So those autosomes are going to give or form your body. They're going to give you specific traits: eye color, height, shape of your nose, shape of your ears, everything. Those X chromosomes are a lot larger. That's for female. Y chromosomes are smaller. A genetic female has 2 X chromosomes. A genetic male has 1 X and 1 Y chromosome. So in a gamete, those oocytes and those sperm, there are 23 chromosomes. They have 22 autosomes and 1 sex chromosome. The sperm is going to carry either an X or a Y chromosome. When they get split off during meiosis, as these sperms split, one will have the X, one will have the Y. In an egg, it's always going to have this X chromosome. So early embryo is this bipotential. So it has the ability to form either a male or a female organs. So at this point, this is where we have this response to genetic sex of this embryo. If it is genetically male, testes will start to develop. If it is genetically female, ovaries will develop. So once those testes start to develop, they're going to start to secrete out that testosterone. That testosterone is what will form that male genital tract. The male external genitals will also develop. In the females, the ovaries will develop because there's no testosterone. This is what causes the female genital tract and the female external genitals to finally develop by default. The default pathway is ideal because male and female embryos are exposed to very high levels of estrogen and progesterone from the mother. So if female sex hormones start to play a role in sex differentiation, then all embryos will develop as females. Sex differentiation, those genital organs develop along male or female lines specifically. So this is where we have these gonadal ridges. These are what develop into those gonads. Those testes are the ovaries, and this comes from the mesoderm. So during the 5th week of development, these gonadal ridges are going to start to develop. And next to these gonadal ridges, we get these mesonephric ducts. This is the structure of the male reproductive system. Then we get a second pair of paramesonephric ducts. These develop lateral to that, and they're going to form the female reproductive system. Both sets of these ducts are going to empty into that urogenital sinus. So early on, that embryo can develop into a male or a female. It's all going to depend on its genetic makeup. Here is where this master switch comes in. On the Y chromosome, they have this SRY. This is the sex determining region. This is only found on the male Y chromosome. If this SRY is present, this is what stimulates the growth of the male reproductive system. So that epididymis, ductus deferens, ejaculatory duct, seminal glands, seminiferous tubules, the prostate, the bulbourethral glands, all of these are going to start to develop with that SRY found on that Y chromosome. In the female, there's 2 X chromosomes. So there is that SRY is absent since it's only found on the Y chromosome. Since it is absent, the female genital reproductive system, that female genital tract, will develop by default. So everything else will start to develop female just by default because that SRY is not there. So that's what causes all of these different features of that female reproductive system to eventually develop. The external genitals, both males and females, they remain undifferentiated until the 8th week. So all embryos are going to have urethral folds, urethral grooves, genital tubercles, and labiosacral swellings. That is what is found in all male and female embryos up until 8 weeks old. So everything looks the same up until 8 weeks. This is when male embryos, because that testosterone is starting to be secreted, gets converted to that dihydrotestosterone, another form of testosterone that is stimulating the development of the external genitalia in men. Because there is no dihydrotestosterone in females, that's what causes the clitoris to form, that labia minora, the labia majora, and the vestibule. So during the first decade of life, that genital system stays in what is known as a juvenile state. By about 10, hormones are going to start to change both the male and the female system, and puberty is going to start. Puberty is when those secondary sex characteristics will start to develop in both men and women. We get pulses or bursts of this luteinizing hormone that gets secreted out because it's being triggered by pulses of this gonadotropin releasing hormone. It mostly occurs during sleep. So once puberty starts, this hormone is also active during the day and night. It increases over a 3 to 4 year period until the adult pattern of these hormones being released has finally been established. So just before puberty, leptin levels are starting to rise. It's going to help to get proportions of adipose tissue in places where they belong. So looking at leptin receptors and research in mice, if they don't have functional leptin genes from birth, they end up being sterile. Leptin is thought then to signal that hypothalamus to start the reproductive functions. So in females, that genital cycle occurs each month from menarche. Menarche is the very first menstrual cycle. This menarche all the way through until menopause, when there is no more menstrual cycle happening. The female reproductive system has a time span of fertility. So for the first couple years after menarche, only 10% of the cycles are going to have ovulation. Gradually, that ovulation will increase. And then as we get older, fertility declines. So between 40 and 50, there's a very small amount of ovarian follicles that are left. Estrogen production starts to decline, and women start to experience hot flashes, sweating, and it tends to coincide with the release of that gonadotropin releasing hormone. Menopause also brings about headaches, hair loss, muscle pains, vaginal dryness, insomnia, depression, weight gain, mood swings. The ovaries will start to atrophy, the uterine tubes, uterus, vagina, external genitals, they all kind of atrophy down. And it's because of the loss of estrogens. Because of those loss of estrogens, that bone mineral density starts to go down. The risks of uterine cancer peaks at about 65. Cervical cancer is more common in younger women. Uterine cancer is more common in older women. In males, that decline in that genital cycle or that function, it's a lot more stable. Males can retain their genital capacity into their 80s or 90s. But at about 55, there starts to be a decline in testosterone being made, and it starts to lead to reduced muscle strength. There's fewer and fewer viable sperm, which causes a decrease in sexual desire. Between 60 and 80, sperm production decreases by 50 to 70%, but there still may be plenty of sperm available. That prostate starts to enlarge. It can enlarge 2 to 4 times. And it happens in most males over 50. Benign prostate hyperplasia is an increase, this is decrease, it should be increase, in size of that prostate, which leads to frequent urination, nocturia, going to the bathroom at night, hesitancy in urination. It's hard to get it started. Decreased force and stream. Post-voiding dribbling, and a sensation of incomplete emptying because that prostate is closing off that urethra, making it harder for urine to pass through. Testicular cancer. Testicular cancer is most common in males between 20 and 35. So the younger aged men. And most of it is from spermatogonia within those seminiferous tubules. There could be some sort of mass in the testes. It causes those testicular heaviness. Feels more heavy. It's not usually painful. It's more heavy. There's a lot of different prostate disorders. Because that prostate wraps all the way around the urethra, it can actually cause an obstruction in that flow of urine. It can be acute. It can be a chronic. You have fever, chills, urinary frequency, frequent urination at night, difficulty urinating, burning, painful urination, low back pain, joint muscle pain, blood in the urine, painful ejaculation. If it's acute, antibiotics can help to treat it because it could be a bacterial infection. But that prostate is usually swollen and tender. Chronic prostatitis, that's an inflammation. Chronic, it happens in men in their middle and late years. That prostate just feels enlarged. It's soft, tender. Sometimes that surface can be kind of bumpy as well. Prostate cancer. Prostate cancer is the leading cause of death for men in the US. Prostate-specific antigen, PSA, gets produced by these prostate cells. It can cause an enlargement in that prostate, and a benign enlargement, or could be cancerous. You can do a blood test to check that prostate-specific antigen, but males over 40 should also start getting prostate exams. This is where this rectal prostate exam, where a physician will actually feel the prostate through the rectum, sticking a finger up through the rectum to feel that prostate. Tends to be an annual exam over the age of 50. They can surgically remove it, radiation, hormone therapy, chemotherapy. A lot of times it's watchful waiting before treating, especially in men over 70. Erectile dysfunction. It's that inability of an adult male to ejaculate or to attain or to hold an erection long enough for sexual intercourse. May not have enough nitric oxide, which allows those blood vessels to vasodilate and blood to rush into the penis. This can cause, there's diabetes, there's any kind of physical abnormalities of the penis, syphilis, vascular disturbances, neurological disorders, surgery, testosterone problems, drugs like alcohol, antidepressants are a big cause of erectile dysfunction, antihistamines, antihypertensives, narcotics, nicotine, tranquilizers, anxiety, depression, fear of causing a pregnancy can lead to erectile dysfunction, fear of sexually transmitted diseases, religious inhibitions, emotional immaturity. There's a lot of different causes for erectile dysfunction. Premenstrual syndrome, PMS. Just like the female cycle is cyclical, so is PMS. And it is physical and emotional distress. It appears in this post-ovulatory luteal phase. And once menstruation happens or starts, it usually disappears. There can be edema, so collection of fluid outside of tissues. Weight gain, breast swelling and tenderness, abdominal distension, headache, joint pain, constipation, skin eruptions, acne, fatigue, lethargy, sleep or anxiety, mood swings, headaches, because hormones are kind of all over the place. We don't know what always causes it, but in some women, regular exercise can help if you avoid caffeine, salt, or alcohol. Eating diets high in complex carbs and more proteins can actually give some sort of relief. We have premenstrual dysphoric disorder, PMDD. This is a more severe version of PMS. But these symptoms also do not resolve once menstruation starts. Suppression of the reproductive cycle that interferes with that gonadotropin releasing hormone actually decreases the symptoms of this PMDD. Could be caused because of an abnormal response in the body to ovarian hormones. Endometriosis. This is where that endometrial tissue is growing outside of the uterus. This tissue is growing in the pelvic cavity. It's usually found in several sites. It can be growing on the ovaries, the rectouterine pouch, outside the wall outside of the uterus, the colon, pelvic and abdominal lymph nodes, the cervix, abdominal wall, kidneys, urinary bladder. And it's growing in response to those hormone fluctuations that are happening. So that tissue is going to proliferate. It's going to break down and bleed, no matter where that tissue is growing. It can cause inflammation, pain, scarring, and it can even cause infertility. They can get some really severe premenstrual pain, and they even have very severe menstrual pain because it is bleeding out into that pelvic cavity. Breast cancer. 1 in 8 women faces the prospect of breast cancer. It is very seldomly seen before the age of 30, and it increases drastically after menopause. Women who have it in their younger years, it's because of an inherited genetic mutation, the BRCA1 or the BRCA2 gene. And a mutation to this P53 gene. I've known people who had BRCA1, BRCA2 genes, and their doctors actually recommended a full removal of the breast to prevent breast cancer from even forming because there's no breast tissue there. It's not painful usually until it's more advanced, and any lumps should be reported to a physician because you don't know what it could be. Earlier the detection, the better the chances of survival. Mammography is the best way to view any masses, any lumps, bumps, anything that can be found, and it can be good at detecting tumors that are less than 1 centimeter in size. So if you have a family history of breast cancer, never had a child, or if you had your first child after the age of 35, if you've had cancer in one of your breasts, if you've had exposure to ionizing radiations, X-rays, excessive alcohol intake, and cigarette smoking can lead to breast cancer. They can try hormone therapy, chemotherapy, radiation, lumpectomy, removing the lump, modified or radical mastectomy, that's removing the breast, or a combination. So that lumpectomy is just removing that tumor and any tissue that's attached to it. That radical mastectomy is removal of that entire breast. Sometimes those pectoral muscles and those axillary lymph nodes in that area. Chemotherapy is used to try to decrease the risk of a relapse or that disease progression. Ovarian cancer. This is the leading cause of death in women just because it is very difficult to detect. So people who are at risk of ovarian cancer are usually over 50. White population has a higher risk if you have a family history of ovarian cancer. More than 40 years of active ovulation. No children, or your first child after 30. Eat a high fat, a lot of fiber, vitamin A deficiency diet. Prolonged exposure to asbestos. Usually there's no symptoms at the beginning. Eventually you can start to get abdominal discomfort, heartburn, nausea, loss of appetite, bloating, and flatulence. Later stages, you get an enlarged abdomen, abdominal or pelvic pain, urinary complications, menstrual irregularities, and even heavy bleeding can occur. Cervical cancer. Cervical cancer usually begins as a precancerous condition, cervical dysplasia. So that's a change in the number, shape, and growth of those cervical cells, usually those squamous cells. Sometimes these abnormal cells can revert back to, or abnormal cells can revert back to normal. Sometimes they're going to progress to these cancerous cells. This is where Pap smears come in. They come in and sample these cervical cells to see if we're finding any of these abnormal cells growing in the cervix. Almost all of these cervical cancers are caused by the human papilloma virus. Some of these human papilloma viruses can cause genital warts. Most of the time, your immune system can fight it off, but it takes time. It is transmitted vaginal, anal, or through oral sex. There is an HPV vaccine available to help try to protect against cervical cancer. Your only sign or symptom really is abnormal vaginal bleeding. Candida albicans. This is a yeast that lives in that vaginal canal. This yeast is a fungus, and it starts to kind of grow out of control. For vulvovaginal candiditis. It is the most common form of vaginitis. So you get inflammation of that vagina, you get itching, like a yellow, cheesy kind of discharge. You get this yeast odor. Can be very painful. Most women will experience it in their lifetime. If you take an antibiotic, it can kill the bacteria that helps to keep this candida in check, and it can cause this candida to proliferate. And that's what will cause this yeast infection. Sexually transmitted diseases or sexually transmitted infections. These are different types of infections that are spread through sexual contact. So we're going to look at these different STIs. Here's an interesting number. So in developed countries outside of the US, there has been a significant decrease in the spread of STIs over the past 25 years. In the United States, it is rising to epidemic proportions. So the United States, the developed country, is completely opposite the rest of the world. So chlamydia. This is caused by the bacterium Chlamydia trichomoniasis. This bacteria cannot reproduce outside of the body. It's able to hide, this cloaks, so it hides itself inside of cells while it is dividing and multiplying. This is the most prevalent STI in the US. Usually you're asymptomatic at the beginning. It's hard to find. So in males, they usually have a clear discharge, burning on urination, frequent urination and painful urination. If they don't get treated, eventually that epididymis will become inflamed. They can lose sterility. In most females, symptoms are going to be absent, and this is what leads to pelvic inflammatory disease. So these uterine tubes start to become inflamed. Increased risks of ectopic pregnancy, causing infertility, scar tissue to form in the area. Trichomoniasis. This is another very common, and it is the most curable. This comes from a protozoan, Trichomonas vaginalis. This is a normal inhabitant of the female and males but it starts to grow out of control. Something impacts the area and causing this to grow out of control. Most people don't even know. They could have itching, burning, genital soreness, discomfort on urination, and unusual smelling discharge in females can be found. Males will have itching and irritation of that penis, burning, and after urination or ejaculation, some discharge can happen. Having trichomoniasis can actually increase your risk of other STIs like HIV and gonorrhea. So gonorrhea, it's a bacterium, Neisseria gonorrhoeae. This is causing discharging from infected mucous membranes is how this bacteria gets transferred during sexual contact. It can also be passed to a newborn through the birth canal. Infections can take place in the mouth, the vagina, the penis, and the rectum. In males, urethritis. They can have pus drainage, painful urination. The prostate and the epididymis can also become infected in those females. The vagina can get infected, causing a discharge of pus. It can cause scar tissue formation, and it can close those uterine tubes with that scar tissue. If that bacteria is in the birth canal, it can be transmitted to the eyes of that newborn, and it can lead to blindness. Most males and females can have no symptoms until it's progressed too far. Syphilis. Treponema pallidum. It's a bacterium, again, through sexual contact or through blood. It can also be passed through the placenta to the fetus. So in this primary stage, it's usually, you can see a painless open sore or a canker. At the site of contact, it'll heal within a few weeks, 1 to 5 weeks. During the secondary stage, this is 6 to 24 weeks, you start to see skin rashes, fevers, aches in the joints and the muscles. You start to feel more symptomatic. And then that tertiary stage, organ degeneration will start to occur. Neurosyphilis. This is if the syphilis virus or bacterium will get into the nervous system. Your motor areas start to become damaged. You may not be able to control your urine and bowel movements. May end up bedridden. If that's damage to that cerebral cortex, can cause memory loss, personality changes that range from irritability all the way through to these hallucinations. Genital herpes. This is an incurable STI. We have type 2 herpes simplex virus that causes these genital infections, which are these painful blisters that form on the prepuce, the glans penis, the penile shaft in males, the vulva, and sometimes higher up into the vagina in females. These blisters will disappear and reappear because this virus is going to remain in the body. Type 1 herpes simplex virus is the one that causes cold sores on the lips. This one is not sexually transmitted. Human papillomavirus, HPV infection. There's at least 200 related viruses in this HPV category. It can infect skin and it can infect mucous membranes. This is the most common sexually transmitted infection in the United States. The problem is most people don't know they're infected and may never develop symptoms. It is very highly contagious. Spread through direct contact. Some types are low risk and do not cause cancer, but can cause genital warts. In other parts of the body, you can get warts on your hands. Other types, there's a high risk HPVs. These are usually cancer causing, cervical, vulvar, and vaginal cancers and penile cancers in male. Sexually contact, vagina, anal, or oral sex. can pass the human papillomavirus. There is no specific treatment. There are several vaccines out for the HPV virus, and they can provide a pretty strong protection against any new HPV infections. Genital warts. You can get a single, or there could be multiple bumps that are forming in that genital area. And it's usually caused by several different types of that human papillomavirus. They can be raised or flat lesions. They can be large, they can be small, they can be cauliflower with multiple finger-like projections that come off of them. Again, they're transmitted sexually. They can appear weeks or months after sexual contact. Even if that infected partner has no signs or symptoms, it can still be passed along. Your immune system is able to defend against this HPV, and the infected cells can revert to normal within about 2 years. But when immunity is ineffective, these lesions are going to appear. There's no cure for genital warts. Topical gels and vaccines are usually the most effective treatment. So, how our genital system maintains our homeostasis, and it affects every system in our body. We talked a lot about it with the female reproductive system, maintaining bone mass. It helps to maintain muscle mass, testosterone in males. So it's going to affect, there's lots of hormones that are involved. So it goes through that endocrine system. There's a lot that happens throughout these systems that maintains our body in a healthy form, maintaining healthy cycles. Thank you very much for listening to this portion of this chapter. Thank you very much, and I will see you in the last chapter soon. Bye.